Okay. Good afternoon and welcome to the Health and Overview Scrutiny panel. I'm Councillor Mark Jeffrey, Chair of the panel. So firstly, just to run through some housekeeping safety information. If there's a continuous fire alarm sound, please evacuate the room and public gallery by the stairwells. Do not attempt to use the lifts. Please assemble at Queen Victoria's statue. In order to comply with the Guildhall's Trust fire marshal regulations, anyone who signed in at the Guildhall reception desk should sign out when leaving the building at the end of today's meeting. So we are, could I just draw everyone's attention to the fact that we are live streaming today's meeting. Everyone speaking will do so via microphone and they will be on camera. Members of the press and public are also permitted to record the meeting on the understanding that it neither disrupts the meeting nor records those stating explicitly that they do not wish to be recorded. Please can everyone use the microphones and remember to switch them off when they have finished. Apologies for me, I've got a cold that I've had for 2 months and my nose keeps running today, and so I'll be coughing as well, so apologies for me. So should we do introductions around the table? So should we start from my left?
Yes, good evening. Councillor Vivian Atchell, representing Winchester City Council.
Councillor Gillian Harris from Havant Borough Council.
Councillor Brennan Higgins and Jude Ward also suffering from a cold as well.
Lisa Gallagher from Democratic Services.
Okay, so members have read the report, so presenters, please just highlight any developments that have occurred since the publication. I've got apologies for lateness from Councillor Vernon Jackson and apologies from Councillor Tyndall, Councillor Oliver, Councillor Gardner, Councillor Raffaelli, and Councillor Evans, Councillor Mignon. So has anyone got any declarations of interest?
No, Chair.
No. So that's all no. So going through the agenda, item 3, it's minutes of the previous meeting. So we've read this. Has anyone got an? Yeah. Okay, so going through agenda item 3, so it's our page 3 in the report. Has anyone got anything that needs amending at all from that? Page 4, 5, 6, 7, and 8. Okay, so we've gone through that. If it's all fine, I need a proposer and a seconder to agree the minutes. Oh, so Councillor Healy, second. Okay, so that's agreed. So we're now on to agenda item 4. So this is the Portsmouth ICB update and the stroke recovery service. So I think I've got down here Ross and James and Cheryl. Do you want to come forward? Hello. So when you speak, if you press the, I think it's the button on the right, that will open up the microphone. So we've read through your papers. Could you give us a brief summary of your report, and then members will ask any questions? I don't know who's going to speak first.
If I can work the technology, that's me. Is that working? Perfect. Thank you very much. So I'm Ros Hartley. I'm Director of Policy, Innovation and Partnerships in NHS Hampshire and Isle of Wight. I've brought 2 of my colleagues here with me today so we can answer your questions and just take you through just the key points really quickly, if that's okay. So the paper just is giving an update on where we are as NHS Hampshire and Isle of Wight, and it's taught with the key things we just wanted to really quickly go through: the strategy, where we are on primary care, because I know that will be really interesting for yourselves and you'd be very interested in that, where we are on hospices, definitely something on the stroke recovery services, and then quickly, I know that this was raised at previous meetings about an update on the baby loss services. So those are the sort of the things we just wanted to go through. So quickly, we know that the system is really under pressure here in Portsmouth, the wider system nationally across the NHS. But despite that, we are seeing some of our services are at an all-time high in terms of access and what we're offering. So we really wanted to talk about some of the primary care, some of our GP, dentistry, pharmacy services. So those are the things that we just want to cover. Nationally, people will probably be aware that there's a 10-year NHS plan, and the whole point of that, they talk about something called a left shift, so how we shift resources and focus much more on preventing people becoming unwell, keeping people well as long as they possibly can at home and preventing ill health. But we also know that there's always that balance between the pressures of the system today and where we want to go tomorrow in terms of that shift to more prevention and looking after people. So I just wanted to use the example, I'm going to hand over to James in a second, of what we're doing particularly in primary care to sort of really start looking at how we, because that's the first point of contact for many people when they come into the NHS. So how do we really make sure we've got a sustainable and effective primary care service for the people of Portsmouth?
Okay. So thank you, and Chair, obviously I was here the last two meetings, and I think it's a similar update really. I think across general practice we're still seeing significant demand. This year across Hampshire and Isle of Wight, if you take October, it was the highest October on record. We saw over 1.2 million appointments. For Portsmouth, that meant 19,000 more people were seen this October versus last October, and year to date we're about 11% in terms of increase around appointments. Same day appointments remain high, and that's above the Hampshire and Isle of Wight average. And the number of face-to-face appointments have increased across all of the practices. When I was last at the committee, I think we were asked for a breakdown in terms of activity by practice. I'm referring to that here. We will follow up with a more detailed report after this committee. But just to call out some of the increases, so the Lighthouse Group practice has seen a 32% increase in activity this year to date versus the same period last year. Island City, similar sort of increase as well of around 16-17%. So our practices are dealing with significant levels of demand, and we continue to look at innovative ways in which we can meet that demand through extended roles in primary care, the use of pharmacy first, and extended same-day access. So I think overall the message is positive for general practice, and as this committee will know, Portsmouth still has quite a low number of GPs per 1,000 of the population. So I think we should give credit to our GPs for the demand they're managing in spite of some of those long-standing challenges. The other thing I'll point to in the report is dentistry. We continue to see an increase in the number of UDAs being utilised this year versus last year, and the mobile dental unit has played a key role in increasing access to some of our most vulnerable population as well. We have changed the way we commission dental services, so we have increased the UDA rate, and we spoke last time about the average rate of reimbursement to dentists, so we have increased that, and we've also used levers such as the Golden Hello process in line with the national contract, and we've allocated 5 Golden Hellos to dentists in the area. For those not aware of Golden Hellos, effectively that's a way of encouraging people to move to an area, provide a service, and it's there to support them with those transition costs. And final point, just to be assured that we have quite a sort of detailed dental plan for next year, with plans in terms of commissioning, and we've just done a procurement exercise that covers this area, and we will be seeking to commission an additional 40,000 UDAs through the contract moving forward. So I'll stop there and take questions.
Thank you very much. So over to members. So Councillor Heaney.
Thank you. Comes as no surprise, I'm going to ask about the stroke recovery service is one of my first questions. Having looked at the report and what it's saying, I wanted to clarify a couple of things. It's interesting that when talking about the Portsmouth Stroke Recovery Service, the way it's described is it's like it's just a service that signposts. It doesn't actually always reflect, in my view, the work it actually does. They do actually provide key worker support. The evidence of that is in documents which have been available and shared with NHS, and I'm surprised that that isn't actually acknowledged as strongly as it should be. Going back to where we go in the review, I'd like to ask a couple of questions about the review. Our page 15, your page 7, says that the review highlighted several variances in how services are configured, delivered and funded, and they're a legacy of previous arrangements. What are you intending to do about that? What do you intend to do about the variances?
Thank you. I'm Cheryl Harding Trustrell. I'm head of local care within Hampshire and Isle of Wight, fairly new appointment, but I did head up the review from the middle of last year around our stroke pathway across Hampshire and Isle of Wight. And as you rightly say, and we've outlined in the report that we have identified some variances. So we are absolutely looking to unify our services across the patch, and the report, the work we've been doing is not only about community services, but it was about the whole pathway and the acute, the rehabilitation services and the longer term services. The piece that I've been directly involved with is with the Stroke Association and looking at the life after stroke model. The data, the quality of data and the frequency of data has been a little bit of a challenge for the Stroke Association, which working with them, we're absolutely assured that they are putting in place the key worker model. And that's our intention is to commission that model of service going forward across Hampshire and Isle of Wight. So we have got equity of funding, equity of access and equity of service model. It feels as though it's a really good direction to go in, and we've been working really closely with the Wessex Stroke Network and the Stroke Association and other providers around what we need to have in place for our stroke surviving patients.
I do indeed, yes. There is a document the NHS produced called a National Service Model for Integrated Community Stroke Services, published in February 22. How far are you aligning what you're doing in Hampshire with that model?
We've done the first stage review, so pulling together what our legacy commissioning arrangements were, so that we know what services we've got where and the activity that are going through some of those services. And as I say, the first stage is we've actually started at the end of the pathway because patients have told us that is where they come out of NHS services and they struggle most. And some of them have reported it feeling quite abandoned. And so we really want to address that feeling for our patients and improve the experience. It's a lifelong life after stroke commitment that we're working with. The next phase through this year and into next year will be looking at the model of rehabilitation services and how they work and flow between the hospital and community services, looking to move the rehabilitation as soon as possible out into the community and making sure we've got the right capacity. So that's our next phase of work, and I'd be very happy to come back and talk more about that.
Yeah, I think that'd be really helpful, actually. I mean, clearly the service in Portsmouth was different from what was provided elsewhere. So you talk about working with the Stroke Association to provide ongoing personalised interventions tailored to individual needs, which is a bit like sort of, key worker type of thing. So will people in Portsmouth notice no change in the way the service is provided, or will they see a change? And if that change happens, what will it be?
I think some people may perceive a difference in service, depending on how they were using the service originally. We're going with a unified model that across the whole of the area. I have direct experience of it in the north of the patch and in Southampton City, and it works very well and integrates with our NHS services much more closely than it appeared the old model appeared to here in Portsmouth. So I think patients will start to see a positive. We may go through a phase of change, which some people don't like change very much, but I think this will be a positive development for our patients and our residents.
Yeah, If I may, Chair, just to follow up, I think the key point is the integration of the service, and I think what we're aiming to do is make sure that we've got more resource in the community that can deal with the needs that we're presenting. I think in the past things have been quite siloed, so this should be a lot more reactive, a lot more integrated. And I think hopefully one of the things that service users will see is they'll see no distinction between the services they access. They'll see something that's very much care plan focused, very much proactive, and that we're about aligning the acute expertise with the community model, so we can be a lot more focused on rehabilitation and getting people back to baseline.
Did you have another follow-up?
I'm afraid I do, yes. So given that you are going to make changes, what will you put in place to evaluate how those changes, how effective they are and how people are responding to them?
So with all of our programmes, we'll establish sort of quality indicators by which we review impact. I think as we develop the service, we'd naturally engage with Health Watch and other patient representatives. So I think we'll be really clear on how we build the service and who we engage in doing that. I think the other thing, naturally, as we commission services, we review them through a cycle. A lot of that is qualitative and quantitative indicators. And I think where this has worked elsewhere, there's been a real focus on patient experience and transition to independence, but also the impact on carers and families. So I think we've got an opportunity to do something that's really multidisciplinary, really integrated, and really focused on getting people independent and healthy in their own communities. And that links in with all the transformation we do as an organisation. And as Ros outlined earlier, that shift left, that movement of resource into community settings will enable that.
Do you have any more questions, Councillor?
I don't have any more questions on this item,
Yeah.
but I'm happy to sort of pause because I've
Okay.
got some other general questions and I'll let anyone else.
Okay, so on this particular item of this part of the agenda, has anyone got any more questions? So do you want to introduce yourself? I said you would be a few minutes late.
Sorry.
Because you were...
Hi, I'm Gerald Dunham-Jackson. My apologies for being late. I got caught in London. On page 11, the primary care update, I was surprised that there was no mention of a service that I understand is fairly new, which is which is the very good out-of-hours team providing additional Saturday GP appointments for when surgeries can't cope, and I've had good feedback about that. The bit I find strange within the report, and I think I now understand where we're at, is it gives the impression that 48% of people get an appointment when they want it, on that day or the next day. So for my surgery, they release the appointments on Wednesday afternoon, and by Thursday morning they're all gone. So you then have to wait for a week until you can ask for an appointment, because they only release them for, and once they're gone, they're gone. So if on Thursday afternoon I asked for an appointment, I wouldn't get one, and I'd be told to come back on the Wednesday of the next week, because that's when they'd open the books again. So it would give, and it wouldn't count as, that would be as if I was asking for one there and then. So the week's delay disappears and doesn't appear in your figures. I don't know how standard that is across all the different surgeries, but it would explain to me the dissonance between what you're saying and what the real life experience is.
Okay, so I mean that's a fair point. I think obviously I wouldn't understand the detail of that individual interaction. I would only say that as patients present to practice, then they'll be triaged in line with clinical need, and all urgent needs would be dealt with on the day. So again, can't make an assumption on the basis of the clinician, but they may have felt that your appointment could be dealt with through another route or another time. But I will look into that, because you're right. I think from your perspective, whilst there's a statistical element to that, the experience that you've received is very different, and we do take that seriously, because at the end of the day you've gone in with an expectation, you feel that hasn't been met. We need to look into that and make sure that's picked up.
I think the point is we've had these sort of figures come before, and it's helpful having the breakdown, but all of our, well, not all of our, I'm not speaking for everyone here, but certainly my, and I know other people's experience here, and when we've asked people outside, isn't that 43% of people can get appointments on the same day or the next day. Councillor Vernon-Jackson, do you want to come back on that?
No, I just think it is right. When you go there and you can't ask for an appointment, and you have to come back a week later to ask for an appointment, then that feels to me like a delay, but in your statistics it isn't. And trying to get statistics and reality to reflect each other is helpful. Otherwise, people don't believe statistics.
No, fair point. And I think there's context to every bit of data, isn't there? I think on that particular point, I'm happy for you to share that example with me outside of this meeting, and I'll have a conversation with the practice, because the key thing for us is that I think the public recognise that they won't always access an appointment immediately. What we've got to be better at is giving a reason why and signposted and giving people certainty around the next step. And it feels like in that example, you haven't had the certainty you would require to be assured that that issue is being managed. So there's something about how we manage public expectation. There's something around how we manage message around access. But I'm very keen to pick that up and understand that.
Yeah, and just labouring the point. Instead of going to see my GP, I was sent to do an e-consult that said, go and see your GP. I was then sent to see another GP who said, go and see your GP. So on the third occasion, I'm actually going to get to where I wanted to go in the first place. But the waste of public resource to get to where we want to do in the first place is depressing.
Before you arrived, one of the things that the chair asked for was that detail in terms of the proportion that were face-to-face, non-face-to-face, digital via e-consult. We've got that data and we'll follow that up with the report following this meeting.
Thank you.
To know that when I talked to one GP who'd moved here from Kent, he said the communication between the NHS services in here was better than in Kent, but it couldn't have been worse.
So I'll take the first part of that comment as a compliment. If that could be minuted, I'd be delighted. And the other point that you made, Councillor, in terms of the out-of-hours services, I think that's a fair point. And just to give assurance, one thing we have done through winter is we've invested more money into our practices so they can do more of the reactive on-the-day demand as well. So I will feed that back, that positive element back as well.
I think everybody's experience of the out-of-hours service has been really, really good in Portsmouth. They do a very, very good job.
Councillor Heaney, is your point on this one? Yeah, do you want to go?
Figures, actually, it's a very good point that Councillor Jackson made about the out-of-hours service, and it's good to praise those that are really excellent, because that's sometimes the time when you are most worried and most in crisis, out of hours. That's the one. And if that service is working well, that's excellent. I suppose I shared Councillor Jackson's sort of, when I looked at these figures, I sort of, what do these figures actually mean? Because it's nice to know that there are more GP appointments in Portsmouth overall, because that means more people are being seen, but I didn't really get a sense, having looked at the figures, that I had any sort of comparison or which practices are getting more appointments than others. Of course, some of these practices will be bigger, have more GPs than others. I mean, I presume Portstone practice is much bigger than anyone else's. So again, the context isn't going to, my practice has a fairly small number, but that doesn't mean they haven't done well. They may have increased their proportion of appointments significantly more than a bigger practice. But I'm conscious that it means extra work, but some more contextual information, maybe we could discuss what that should be, out of this meeting, to give us a clearer idea of what this actually means. I mean, it's a good news story that there are more practices, more appointments, but as I say, I'm not quite clear that I understand the context of all this, given the figures are fairly raw.
Yeah, and it didn't make it into this report, but I'm accessing data now, which is up to date in terms of exactly that. So what's the rate per thousand? How is that adjusted for staffing levels? What's the raw count this October versus last October?
Yeah.
What does that mean in terms of year-on-year difference? We can add to that list size, actually, to be useful to you understand
That would be helpful.
how that breaks down. So I think we can work with Tom and we can share that with a bit of context. And then perhaps any feedback on that between now and the next meeting can then drive how we develop the report for the next meeting, so we're addressing those issues in advance.
That sounds very helpful. So you can look to get us figures before the next meeting, do you think, and circulate it?
Yeah, so there's figures I'm looking at now that didn't make it into the report because of timing that we can share, and I can provide some context on that. I think the other thing I'll provide is the size of each practice, so you can see the increase relative to list size and number of doctors.
I know it's a key interest for several members here. So is there any sort of qualitative work done on, in effect, I don't like the term like customer experience, but it's sort of what Councillor Jackson said, is that my experience is when you ring through, sometimes you're put into a loop. You're told to, you miss the time slot that you're supposed to ring through. Then you do the e-consult. The e-consult then doesn't work. sometimes the e-consult you're only allowed to send information to the e-consult through various times on my practice, which is really bizarre. So there's lots of things that aren't very customer focused, but more importantly, well, not more importantly, just as importantly, is taking up a lot of your time and then other people's time. So pharmacies, because it's pretty bad, I think, my experience.
So there's formal mechanisms for patients to feedback. So that's the GP patient survey. There's other mechanisms that rank practices in comparison with best performing, and in that regard, in terms of public opinion, there aren't any sort of surveys that get into the detail of the patient journey as such. But there are opportunities for patients at all times to feed back into the practice, or use the patient participation group, or make comments to the ICB through our patient advice and liaison service, so we can look at that and we can investigate that. As part of we're resetting the way we do same-day access in primary care, so we are naturally looking at flow, we're looking at the front end of the practice, how people are triaged, how data is used, are we creating artificial duplication, if you like, at that front end, and how can we be more efficient. So we can give you a view, and we can give you a view of that pathway, but the way a lot of it will be dependent on patients sharing that experience with practices. But again, if there's any examples within your constituencies you want to share, feel free and we'll pick up.
I appreciate what you're saying about the sort of feedback, but it is slightly different. What I'm saying is that actually, do you do any work on actually real-time customer experience? So, you know, does anyone ring up a surgery and try and book an appointment, a matrimony appointment, and follow through the processes that they tell people that they have to do? And the same with online. Quite often, if you look at certainly from my experience of my GP practice, you do the online, go to their website, and it's contradictory information. I won't labour the point, but that is my experience.
Yeah. So just on that, in terms of our sort of digital solutions and how people access the surgery and how online appointments work. So we're part of this National Primary Care Access Recovery Plan, where we make investment in phone systems, the use of IT. Through that, there's a process of assessing the impact of that investment, if you like, in terms of the flow and the experience. So there isn't a formal process within the ICB whereby you would almost have a wrong term, but a secret shopper who would test that process. But there is a process within the ICB where we do review the efficacy of those systems, the effectiveness of those systems, to ensure that they are streamlined in demand. But you do make a good point in terms of, do we actually need to test it from front to end in a sort of an anonymous way to review experience? We can certainly look at that. But just to be assured, all of those systems are reviewed and looked at on a regular basis.
So on this particular point, I've got next, if it is this particular point, I've got Councillor Ashwell, Councillor Heaney, then Councillor Vernon Jackson.
I'm going to change the topic, though. I'm going to dentistry, if that's all right.
Yeah, can we stick with
Okay,
this one first, and then
sure.
we'll come
Okay.
back on this one as well? Yeah, okay, so Heaney on this one.
Yeah, just to talk about the way e-consult works. My surgery is about 10 minutes walk from where I live. I dropped in to see them and asked about something, and they said, "Oh, do an e-consult." So I went into work, came home in the evening, went to go an e-consult, and say, "No, you can't access it." The fact I'm often leaving for work before 8 o'clock in the morning, when it opens, e-consult opens, means as a working person, I can't get e-consult because I'm at work most of the day. So I basically didn't bother in the end. So there is still something that's bothering me, but I haven't actually done anything about it. And that's the problem. You can't use these services as when I did make a polite complaint about the access, and the email I got back basically said, "Oh, we have to manage the workload." Well, I understand that. But on the other hand, how useful is it for people who need to access it out of hours? So I think there is an issue there about how that happens. I understand the problem. Of course, thousands of people do e-consult, and your GP is spending a long time dealing with that. But it doesn't work when you can't get someone to give you an appointment.
And of course, then people get more phone calls in.
Yeah. I mean, I just haven't bothered to go back.
On this particular point, I've got Councillor Harris, then Vernon Jackson.
I want to move on to...
Okay, so we've got Councillor Harris, then Councillor Ashwell, then Councillor Vernon Jackson.
Just very, very quickly, I'm from Havant Borough Council, and I think this is only my second meeting I've come to, so I'm not quite sure the scope of these reports, but I did point out it's all very interesting, but from my point of view, there's nothing here about GP surgeries in Havant, and I wonder whether that is the statistics can be included, or whether that's out of scope of this particular your data. So
I think it does
just
cover
to make it
this
slightly
area,
more
but
interesting
I
for
don't
me.
know.
I'm assuming it's in the scope of this committee, Chair.
So we cover the QA area, this committee.
So I mean,
Yeah. Any more on this particular issue before we go on,
Yes,
Councillor?
just going back to that then, could we include Whiteley as well? Yeah, thank you.
Again, assuming that's in the scope of this.
It is.
Yeah, it is, yeah.
It is.
Good. Yeah, and we've raised this point before, actually, on not this item, but other items. Yeah, yeah. So next I've got Councillor Ashwell.
Yep. Just on the dentistry, I mean, it's great people being seen, but do you know, do we still have a waiting list for people trying to access the NHS dentistry?
Yeah, I think that's a reality at the moment in terms of the demand for dentists and the number of dentists that we've got. So, yeah, we do have a waiting list. We don't report a waiting list in the way other services do, but we're starting to get a better indication of the number of people who are waiting to register for an NHS dentist, and those that have registered for an NHS dentist, their average wait to first appointment and first treatment. So that is something where we're improving, and we are working with contractors and providers of NHS dentistry to, in some ways, make them more accountable for that length of time between registration and first appointment. But you will know the realities are such that there will be a waiting list in this area for a long time to come, I think.
I've got one on dentistry. So just feedback, really. So in my ward, I have an advice surgery in part of the ward, which is Somerstown, and they have the Dent Aid mobile dental unit, and lots of people are really positive about it. Okay, any more on dentistry? Okay, next I've got Councillor Vernon Jackson.
Could I go on to Rowan's Hospice? It's good to see you're going to put people onto NHS contracts. The Rowans have reduced the number of beds available from 22 to 16 already, so there is and they've had to reduce staff and are continuing to do so, and therefore the service to local residents is not as good as it was inevitably. But one of the things they've talked to me about is that there is very, very different levels of NHS funding to different hospices within the area. I'm not going to say where because I don't think that's appropriate. But Rowans, I know, feel very hard done by that the amount of support they get from the NHS is pretty limited. And things like the increase in national insurance has really hit them very, very hard. They've got to find an extra £250,000 just to keep Rachel Reeves happy. And I don't know if Graham is writing a cheque for that, or the Labour Party locally are writing a cheque for that. But it's a real problem for them, and it's going to mean services are going to be cut.
I don't know if, Cheryl, do you want to come in on the context around Rowans, and I'll just speak generally then around our commitment in terms of development, etc.
Yeah, sorry, tech. We're working very closely with all of the hospices within the Hampshire and Isle of Wight footprint, because we've very much heard that there is inequity in the way that they have been funded historically. One of them has been fortunate and been on an NHS contract, not perfect, but at least it has given them some security. The others that are on grant agreements, that's been very variable for them. We have agreed, and we're in the process of moving them onto NHS contracts, so they will all be on the same footing. And we have done some work in the last year at looking at a fair and equitable funding model for all of them, and we're in the process of working out how we can roll that out as rapidly as possible to support them. Very aware of the Rowans' financial position, and we're working really closely with them.
Okay to come in? Yeah. I mean, the only point I would add is, in addition to that, I think in terms of our service improvement and development moving forward, it's about how do we bring our hospices into those transformation initiatives. So if you think about frailty, that's a big area of focus. There's real opportunities, I think, for our hospices to be part of that service model and be part of that approach in terms of reactive care and supporting more people at home. So I think Cheryl's right. There's something about the funding we provide and the stability we provide, but equally I think their sustainability is often dependent on their role as part of that wider NHS and their involvement in service delivery. And I think for us it's about moving them more into our strategy for out-of-hospital care as well.
I wouldn't wish you to go away with any doubt about how valued Rowan's is by the local community, and if they ever felt threatened with closure because they hadn't got the money to keep on going, that would be devastating for the local area.
I may come back, Chair. Yeah, absolutely. And we hear the same message from all of them. They are absolutely, the hospices are a community asset, and they do far more than we commission through the NHS. And you know that's why we know that they are so valuable, and we really want to work with them and support them.
Thank you. Any more questions on this issue, Councillor Heaney? No. So, Councillor Heaney.
I just wanted a quick clarification on some figures. On page 13 of the report, you talk about pharmacies providing 5695 consultations. Does consultations include providing vaccinations, or is it consultations where someone comes to ask for advice about a particular condition? I seem to have floored people with that question. So, the 5695 consultations on pharmacies, does that include vaccinations? Or
No,
there's
a separate number in terms of service provision, sorry. So that's effectively our Pharmacy First service, so people who are redirected into pharmacy for minor illness consultation. We do have quite impressive figures on vaccinations as well, which we can share. But I think we do want, I mean, our pharmacists can play a key role in sort of extending that. And again, it helps with their viability as businesses as well, if we can get more of those services into that setting.
Have the vaccination figure as well, just so we know what role they're playing, because they do play an important role. I mean, I got my COVID jab through my pharmacy, so yeah.
Any more on this issue or any other issue on this report? Can I just ask, so in terms of on the front page of the report, the second paragraph, it says we're stabilising our organisational finances. Are you able to give any sort of headline figures about where we are, how we are in the financial year? And I appreciate you might not have this information, but it's probably a large thing on your agenda.
Okay, so I'm not going to provide the figures, but what I will say, we are in a much better position than we have been for the last 18 months, and we're due to sort of break even by the end of this year.
Thanks for the update. Thank you. Any more questions on this report, members? Okay, so we note this report, I think, and thank you for your time. You're welcome to stay for the rest of the meeting, but we do understand you. If you want to, you can leave, and have a good evening. Thank you for coming. So the next agenda item is agenda item 5, which is the South Central Ambulance Service. So Jodie, could you come forward, please? Hello. If you, we've read the report, so if you could just give a brief summary if you feel that you need to, and we'll then have some questions. Thank you.
Thank you, Chair. Thank you, everyone.
Chair, before you start, Jodie, we operate on black and white, and it's very difficult to read the report which is clearly produced in colour in black and white. Could you explain what the slightly different grey bits mean?
I will certainly do my best.
You can't afford to do colour copying, unlike the ambulance service.
No, and I will take that into consideration for when I do the report next time and try and do that slightly differently. So if we're just talking briefly about the charts that you can see, so the 24-25 line is the higher line, which is showing an increase in demand, and the 23-24 is the lower line, which just indicates that we've seen greater demand. And the same for the acuity. The southeast line is the higher line, and SCAS is the lower line, just to show that we continue to see above the SCAS average for Cat 1 and Cat 2 demand. I think that's probably the main ones that you need from there. So, yeah, so in the handover delays, the first pillar is the 23, the second pillar is the 24. But I will bear that in mind for next time. Thank you. So yes, as said, take that the report has been read. The only change to the report actually is that we moved just this week from REAP 4, which is extreme pressure, to REAP 3, which still reflects, I think, the severity of the pressures that we're experiencing during winter, but is showing that things is a more sustainable position, which we would expect to see at this time of the year. So just going through briefly through the integrated care, the main highlights there, I think, are around the single point of access. So we've seen some more specialisms move into our control room. They are signposting some of our lower acuity patients to a more suitable pathway, which has seen some real benefits to the Portsmouth and South East area. That has been deemed as a success and is being continued on a permanent basis, and they are recruiting into those posts as we speak. The other thing I'm pleased to say, having been involved at the beginning, is the social worker line is now back up and running, which very much focuses on social needs as opposed to clinical needs. So we've now got that much better balance of clinical and social need, looking at that right from the point of call, which is a good thing. Demand, I think, has reflected the winter pressures, which has already been mentioned is across the whole of healthcare. So nothing particularly unusual from our perspective. In regards to the performance, I think the highlight there is around the Release to Respond initiative. This is an initiative that has been brought across. It's not a local, it's national, and has been with us since the 12th of December as part of the PHU process. Very much a collaborative piece of work, and enables crews to safely hand over patients that haven't been able to be handed over within 45 minutes, and release to respond to patients that are waiting in the community, which has always been a very high risk area from our perspective. The other thing to highlight in the report is around the enhanced patient safety procedure. I just wanted to talk a little bit. That's a tool that when we are at extreme pressure, where patients are at risk and demand is outstripping resources, we will enact this procedure, which enables us to treat our lower acuity patients slightly differently. There are very strict guidelines around that, and it's something that is introduced as a very extreme pressure, with very strict guidelines and review periods in place for that, so that it just changes the way we respond to our lower acuity patients, so that we can really focus on our particularly sick patients in the community. We do continue to work collaboratively, not only locally, but we're also working collaboratively with other ambulance services, looking to find best practice, to see what others are doing well, what we can share with them as well. So we've been doing some of that. We had some meetings with CCAM just to have a discussion to see what we can do collaboratively there. And that feeds into our Fit for the Future work stream as well, which we're doing alongside that, just to make sure that as an organisation we are fit for the future as we move forward as regards to healthcare. So I think that's probably the highlights of the report, so I'm happy to take questions.
Thank you. So we've read the report. So got Councillor Vernon Jackson.
Well, two things unrelated. First of all, how's the new A&E doing at QA? It looks from your figures as if the handover it's working better and you've got less time hanging around outside. So that was the first question. Pregnant pause.
Yes, so I think it was twofold. So we saw the opening of the new emergency department on the 26th of November. There was quite, again, very much integrated collaborative work to ensure that smooth transition, both from us supporting our staff, but also enabling the support of ED. And I think that there were certain processes that were put in place. I'm not able to speak obviously for the hospital, but I'm aware of other processes that were put in place for that transition, which I think helped. But then along with that came on the 12th of December the Release to Respond initiative, which has made a dramatic difference to our amount of holds and delays that we have seen at PHU in past years. It's been a staggering change, which has made that big difference. So I think it was twofold. I think the two coming along together and the additional processes that were put in place to support that.
That's really good to hear. A completely different issue. Having spent too long over the last year in A&E, most of the time everything seems okay, but at times people are abusive, violent, and whatever. In terms of your staff, how often does that affect them? And are you able, if push comes to shove and it becomes something that's repeated several times, to be able to say that people are not safe to interact with?
Yes, thank you, and I'm sorry if you've spent too much time in A&E. I'm sorry to hear that. Yes, so we do find ourselves confronted with violence and aggression on a regular basis. Unfortunately, it is part of the nature of the work. The crews that are on the road and confronted with that have various tools at their disposal to ensure that they're safe. They can press a button on their radio which automatically alerts everybody that they are in danger, right up to the point where they can, if they've just had an interaction that's been unpleasant for whatever reason, they can then report that through our reporting system to say that an adverse incident took place. Because what we can sometimes see is that through no fault of their own, patients that are unwell, and it's their illness that brings sometimes that aggressive response. We all know that dementia patients or patients that are unwell with diabetes can sometimes display those sorts of behaviours, and so it's not always violence portrayed because of the sake of violence. So we do have very good reporting systems so that we can see where we need to focus some of our safety measures, but our crews are very aware that they can withdraw if they need to, if they are in particular danger. We teach and repeatedly reinforce dynamic risk assessments so that when they're on scene they can dynamically risk assess a situation, so that if they feel unsafe they can withdraw and call for police or other additional support if they need it, or they can withdraw and ask sometimes even just bringing the patient out of a dwelling and out into their space is one way of dealing with it. So we offer all those tools to our staff to ensure their safety.
And I have to say I've had outstanding interactions with the ambulance service. They've been absolutely, truly wonderful.
Thank you, I appreciate that, and I will pass that feedback back from today. Thank you.
Are there any more questions on this issue? Councillor Ashwell?
Could I just ask then about the ambulance staff, if there is a violent incident, what support do they actually get? Because, you know, those thoughts or whatever happened can keep coming back.
Yeah, so we have a trauma response programme which has been developed, has come from the military, so that's mainly for sort of to help prevent post-traumatic stress disorder. So immediately after an incident they will receive a debrief, they will be offered all of the tools that they need to support. We've got employee assistance programmes which offers counselling which happens within 24 hours. We have special trained members of staff that will interact with them immediately so that they can assess the level of trauma they've sustained and how best we deal with that going forward. We've got occupational health support. All of our staff kind of counsel each other a little bit because very often we know what they've been through, so a lot of our managers are very experienced in that being able to support staff in that way. And then we've got much longer term, should they need longer term support, we've got, as I say, extensive counselling that staff can access. We support them through phased returns into the workplace if that's what's needed. So there is an extent, because we recognise how damaging it can be if we don't manage it well. And I think we've seen really positive results over recent years compared to what might have happened sort of 10, 15, 20 years ago with the immediate response to those sorts of interactions.
No, it's just great they're getting that support. Thank you.
Thank you.
I've got Councillor Harris next.
I mean, this might be. Just want to go back to the release to respond because it is quite a staggering difference that you made, and I wonder if you can. can you explain a bit more detail exactly what is the agreed process? Because, you know, it seems, you know, if the, you say after 45 minutes, well, presumably that always happened before. So I think just a bit more detail on how it actually happens.
Yes, of course, and obviously it's difficult for me to speak for the processes that are happening in the hospital, sort of beyond the front door, but we worked very closely with Portsmouth Hospital to ensure that when this process came in that we could safely hand over our patients. While that 45 minutes is ticking on, if we haven't been able to hand over within that time, the emergency department staff, right from consultants and site managers, will be looking for a care space to take that patient into. They will then tell us where they want us to hand over our patient to, which is an appropriate care space for the individual patient. We do recognise that there are times when that can't happen within the 45 minutes. We have seen, and we're trying to sort of see, it's a bit early days, but trying to see themes and trends of the types of patients that are struggling to get in with the 45 minutes. But it's definitely not a 45 minutes, that's it, we're off kind of thing. It's definitely working together with ED, so we let them know what we're coming in with. We give them a really good handover so they know exactly what we've got. They then will work to ensure that the care space that is going to be found is the most suitable. They will then look at what patients they have in the department and look at a most suitable place for them to go as well. So it's very much a sort of staggered process with a lot of communication in between, and the handover is given to clinician, and also we have our electric patient record, which is already uploaded to the hospital, so they have a clear sight of everything that has happened with that patient while they've been in our care before they were handed over.
Any more questions at all, members? Jodie, thank you very much for coming today. You're welcome to stay if you like, but we understand if you need to go, so thank you. Oh,
Is there anything we could do to make things easier for your staff? Apart from getting rid of all the roadworks?
Roadworks don't worry us too much, I have to say. I think just knowing that when we see, because thankfully we do see a lot of compliments letters, as well as letters of complaint, concern, which we take very seriously. But we do see a lot of compliments letters and thank you letters, which I think you can't put an emphasis on how amazing that feels. We have a sort of process where we feed them back electronically, but also there's a little brown envelope that turns up in the crew room, and you can see the crew sort of looking for their names to see if they've got a letter. So I think that it can't be underestimated that when a service it goes well, it's important that the crews know that. And we've learned as an organisation that we're doing better at that. I don't think we did that as an organisation very well, to say thank you to our crews for the job that they're doing so well, particularly around sort of exploring pathways, etc. So we're learning better to sort of compliment our staff as well as look at some negatives. So, but that absolutely, if we can see any positivity or any sort of kind words that said to the crew, it doesn't go unnoticed. Thank you.
so just checking, any more questions from members? No, thank you. So Jodie, yes, so thank you very much for coming today and for the report. You're welcome to stay, but if you want to go, we understand. And we will, we've noted the report, so thank you.
Thank you, Chair.
Okay, so members, and the next item is agenda item 6, which is the public health update. So I've got down here Dominique, Jane and Andrea. Could you come to the front when you're ready? Hello. And so welcome to the meeting. When you speak, if you could just put the microphone on, which is the button on the right-hand side, and turn it off when you've finished speaking. So we've read the report, and I just wondered if you wanted to give any brief summary before we ask questions. Thank you.
Thank you, Chair, and everyone. I'm Dominique Latouze. I'm Assistant Director of Public Health. I'm here on behalf of Helen Atkinson today, and I've got my colleagues Jane Leach and Andrea Wright with me. So I was going to give a brief summary, again, recognising that you've read the papers of the business plan and highlighting some things from this year, and then I'll pass over to my colleagues to go over the brief summary of the other papers in your pack. So the priorities for this year, 24-25, for public health have remained the same, broadly the same. There's 8 priorities for public health around reducing substance misuse, including alcohol harm, smoking, a real big focus on smoking this year in line with national plans, reducing unwanted pregnancies through increasing access to long-acting reversible contraception, continuing to reduce the transmission of STIs, including HIV, a focus on positive mental health and well-being, and we'll touch on the suicide prevention work in a moment through Jane's report, a healthy weight, and again, infant feeding comes in to that, so we'll touch a bit more on that. Continuing to look at the negative health impacts of the natural environment, and this year really focusing on climate change as well and the health impacts of climate change, and then continuing to our work on health intelligence and research and sort of 3 things that we've really thought a lot about this year. Firstly, we've been successful in a £5 million bid from the National Institute for Health and Research over 5 years to deliver a research programme, the Health Determinants Research Collaborations Scheme, really trying to boost capability and capacity for research in the city, focusing on health inequalities and understanding how communities experience health and access to health services, and how that can be improved through local research. Focusing on those building blocks of health, housing, education, air quality, access to green space, and so on. And that has launched now in January this month, so we'll expect to come back and report on that as we go forward. Secondly, smoking cessation, as I mentioned, in line with the national work on this, we've had a big focus on reducing smoking. We always do, but we're really doubling down on that at the moment through recruiting new smoking cessation advisors. And we're seeing some improvement in the city. We've traditionally had slightly higher smoking rates in the population, but we're currently seeing smoking prevalence of adults has decreased from 14.7% in 2022 to 10.1% in 2023, which is now lower than the England average. And we're particularly focusing on smoking in pregnancy and in routine and manual occupations. And have had some success there. And then finally, the Director of Public Health's annual report this year focused on sustainability in health and climate change and the impacts that we're seeing now on climate changing and that we might expect to see in the near and further future. Really focusing on how we adapt to heat, excess heat, flooding, air pollution and insect-borne diseases as the climate changes. So I'll pass over now to Andrea, first of all, to talk a little bit about infant feeding, and then we're happy to take questions after the suicide prevention update as well. Thank you.
Hi, thank you. The infant feeding update, I appreciate you've seen the strategy and the slides as well, so I'm not going to go through very much, but the version you had for the strategy was a draft. Final amends were due in last week, so it has been updated a little bit since then, but nothing major. So our vision remains the same. We are very much committed to recognising and valuing infant feeding, because sometimes it can be overlooked in terms of the benefits it brings for health and well-being for the infant, but also the parent and caregivers as well. We remain committed to the same aims, so creating a positive infant feeding culture, increase the health and safe infant feeding practices, and ensuring that the information that we are given is evidence-based and timely. So one of the key things around infant feeding is breastfeeding, and we will always stand and say that is the best nutritional choice for feeding infants. But we also recognise that not everybody can or chooses to breastfeed, so we're committed to ensuring that support is available for those that choose other forms of that first feed, whether that's donor milk or combi feeding or formula. So it's ensuring that we're using the evidence that we know, regardless of the feeding message, is the best for that infant, and not only the short term but their long term health and outcomes as well. That's it.
Thank you. Did you want to speak, or should we go over to members? Like, that's what I saw.
Yeah, that's fine. I will go. I won't take much of your time for sure. So the papers you have in front of you is an outline of the approach we take across the city with a lead by public health around suicide prevention. So it's evidence led. We have local evidence. We also have national evidence, and then we also have real-time data that comes in from our police. So we call that surveillance, so we can be much more adaptive with the response if we are picking up that there might be cases that are linked with each other or high-profile deaths, where we'd be able to respond in the local area and try and minimize the impact of the death itself. We also use the evidence to commission services identified around need, and particularly, from 2020, this is 2025. So from this year onwards, we have an investment from the NHS in Hampshire-wide area of just over £1 million to provide bereavement support for families and children who've been bereaved by suicide across Hampshire. So Portsmouth City Council are commissioning that on behalf of the NHS. So that's a really useful cross-regional piece of work. We're evidence-led, and then locally we very much organise around the Suicide Prevention Partnership. And you can see there on the second page around the sort of aims and objectives. And those aims and objectives are based on international evidence that identifies 6 pillars. We've also included develop and maintain a city and sector-wide leadership for suicide prevention. But the other activities are evidence-based. Those are, because suicide is not a not complex situation to try and reduce suicide. So a many-pronged, multi-partner approach is required. So these objectives are based on the types of activities that have been identified as more than likely to reduce suicides if implemented in a local area. So we try and cover all areas. We do a sort of wider universal engagement around suicide prevention as a life skill. Having a conversation around suicide as a life skill, and then more targeted work based on some of the data that we gathered through the coroner's records. And last year, we focused very much on young people. Our national figures also and our local figures show that middle-aged, both men and women, are indeed at risk. But we saw something which was unusual from the national data in our local data. Now, these numbers are very, very small, so they're not statistically significant. So we're not going to blow it out of proportion, but it just helps focus our minds. And we thought, okay, there seems to be a little anomaly with the national figures, which shows that our younger people are struggling. So we decided to make a direct comms campaign to speak directly to those distresses or those experiences. Our rates have been going down since 2016, and we are now roughly the same as the English average of about 10.9 deaths per 100,000. So that's it, yes.
Thank you. So over to members. I've got Councillor Vernon Jackson, Councillor Heaney.
First of all, my apologies. I have to run in a minute because I'm chairing another meeting elsewhere in the city at 7. A question that's been asked of me, which is a Portsmouth and area specific thing, is when we got suicides, in death certificate, etc., it'll have their occupation. But that's only their last occupation, and there's issues been raised with me about the number of people who have served in the military, for whom suicide is what happens, and whether there's work we could do with the coroner to understand if this isn't so or not, and whether to not just ask what the last job somebody had is, but whether they had any time in the military over their career. Because there is a real feeling that in people who have been in the military, suicide is a much more frequent occurrence than in other groups. But I don't know if we've got any data that shows if this is so or not. If we did manage to get data, it would mean either we could reassure people or we could try to do some work to target people from a military background to be able to see if we could give people some of the skills and back up to make sure that this wasn't the outcome for them.
So there are a number of pieces to that, but the first one is that there may well be data out there, but the data from the coroner's records we had in our last audit, we audited 52 files. 2 of those we were able to identify that they were veterans, and that's out of the 52. So we get that feedback also. So your suggestion around working with the coroners is a really good one, actually, because that's where the quantitative data comes in. Another route could be possibly with the local service, like the military, the Navy themselves. Actually, that could be a more direct route.
The feedback I have from people who've worked with people in crisis who are veterans is often they're the ones who have the most problem with parts of the service is, and with the mainstream service charities as well. They're the people for whom it's been a bad experience, and therefore going to the British Legion or whatever doesn't catch them, because so that first thing of understanding the size of the problem in terms of doing some research and whether the coroner is able to do anything to be able to find out about whether there are service histories with people would be really, really useful before maybe there's work that we have to do, particularly here in Portsmouth as a military city. And often it's the people I've met who've been are not naval, they're often army. But they come here because this is a military city, even though it's not their bit of it, if you see what I mean.
Well, I can certainly ask the coroner, start that conversation, and also we've just appointed a cruise as our bereavement support service for those bereaved by suicide, and they're connecting in with the army. So actually there might be some routes there. But I hear what you're saying is understanding the size of the problem, and then we can move from there. So I will move to identify relationships and sources of data, and then relationships in order to gather the data.
Okay, next I've got Councillor Heaney.
Yeah, I want to ask a question about the public health intelligence research. As you might expect from somebody in my background, I'm all in favour of good research. But I wanted if you could tell me a little bit more about what they'll actually do, because the funding is for 5 years, and I'm assuming that is when it ends. So we wouldn't maybe be able to do a sort of long-term project about tracking people's health over a longer period of time, because that wouldn't come out of the, you know, we won't be able to fund it over a number of years. So have you got any particular examples? Because although it talks about broad general things, I mean, are there projects that people had in mind which will fit into this that we've already been developed, or can you give me some sort of notion of what might be done here? Be helpful.
Yeah, thank you. One of the things it's not going to be is a cohort study of people in Portsmouth. So we're not going to be following the same individuals through the 5 years. It will be a series of smaller programmes, like I said, focusing on some of those more sort of local community issues that have emerged over the last year of development. So we've had a development year where we've appointed a team of staff, and some of those staff were so-called community connectors who've been working with community members to identify topics. So because we're still only at the very beginning of or the end of that development year, we've really only got a very broad brush themes at the moment. Like I said, sort of housing, education. We're thinking about some of those issues around food banks potentially, and with the idea that those the reveal, or the way that those issues will reveal some health inequalities, we'll be able to kind of put back in. So it's a very vague answer at this stage, but we're still developing up some of those skills. I think one of the things that we're really looking to do is, in addition to the topics, is going to be the development of the skills that we're going to be working on within the council. And also with the community. So a lot of the focus will be on training as well as the topics themselves.
Can I start? I mean, it's interesting. I mean, do you know what won the bid for us then? Because it's a lot of money to be put into research. And is it based on our track record, or do you know how we actually won it? Because I know how difficult research funding can be to obtain.
Absolutely, and I'm not the right person to go into that, because our research...
Maybe we'll cover that outside of this meeting. That's okay, don't worry.
Any more questions from members at all? I've got one, actually. I made a note earlier, just so I don't know if you have this information. So it's on our page 38, which I don't know what number it is on your report, but it's to do with reducing the harm caused by substance misuse. And the last bullet point related to the percentage of drug users not in treatment is low in ports within the English average. Is there anything? Are there steps that are being taken to reduce that figure? And do you know what they are? And are you able to explain?
Yeah, so we've got a lot of focus on getting people back into treatment, and this figure has improved over the last few years. A lot of the work that we're doing is really trying to encourage people to engage with services in the first place, because obviously it can be a revolving door. Sometimes not everybody that goes into treatment in the first place successfully completes treatment. But Alan, who is our drug and alcohol lead, is much better to give you much more detail on that. So if you've got specific questions around that, I can come back and answer those.
That's fine, thank you. Any more questions from members?
Just had a quick
last
one.
question.
Quick one about breastfeeding. I noticed on our page number 36, the percentage of white females who breastfeed against other Asian groups, it's quite low. Now, I just wondered how we can go about improving that, or what's the plan to improve that?
Thank you. Yeah, we use our data, which is why it's one of the key things we wanted in our strategy, because the strategy obviously is for that Hampshire and Isle of Wight area, so that we're working on it together. But the data tells us that white British are less likely to breastfeed. It also tells us that the younger population are less likely to breastfeed. So if you're a younger white, that's a sort of double whammy in terms of your likelihood to breastfeed. So that's when we look at what resources we have and how we can target them. So we've got lots of different options, as well as our maternity service and our health visiting service, who do a lot of the work around that early breastfeed. And we've got peer supporters as well. So we have currently the Breastfeeding Network provide our peer support in Portsmouth, and they work out of our family hubs and also out of the hospital, and they go in and they're fully trained service, and they go in and support on a one-to-one basis or in a small group. They come along for advice. So it's about us looking at understanding who is least likely to breastfeed and put the additional resource in there. There's also an awareness raising as well. And the biggest thing for us is the culture shift. So as a nation, if you compare ourselves to like some other countries internationally, breastfeeding rates in the UK are lower. So it's about working across the system with individuals, with community, with partners in various ways to take the stigma out of breastfeeding, and that in itself will hopefully help those white younger women to feel comfortable breastfeeding. So it's tackling it from a range of angles, I think.
I've just become a grandma about 5 months ago, so seeing how my daughter's been reacting, and you know, it has positive and negative, to be honest. Just having that extra support for that, needs to be there.
Yeah, it's one of those things. We know that, like, from a health perspective, breastfeeding is the best, but it's difficult. But with the right support, that makes that journey a lot easier. So that's what we're focused on, is increasing our rates, but in a supportive way, and that's not just the support for the individual, but it's those that also support the individual as well. So the family members, whether that's partners or grandparents, which is great, congratulations, and then within the community as well.
Thanks.
Thank you very much for your report. It's always really comprehensive and laid out really well and clear. So thank you very much for your time. We've noted the report, so you're welcome to leave now. In terms of, do you need to go literally this moment? Yeah. Okay, so I'll close the meeting now, so thank you very much. Thank you.